Good morning, everyone, and welcome to our webinar this morning, Selecting and Implementing Evidence-Based Practices to Address Substance Misuse Among Young Adults. Our speaker today will be Dr. Kim Dash, Senior Research Scientist at Education Development Center. The Great Lakes PTTC is funded by SAMHSA to support the behavioral health workforce in Region 5, which currently includes Illinois, Indiana, Michigan, Minnesota, Ohio, and Wisconsin. So welcome Region 5 and welcome especially to everyone outside of Region 5. We're happy to have you. Our work is supported by a SAMHSA grant. And this presentation, the opinions expressed in this presentation are the views of the speakers and do not necessarily reflect the official position of DHHS or SAMHSA. Our webinar format today will be that it will be broadcast through your speakers on your computer, so please make sure your speakers are turned on and up. There is no call-in number available. This webinar will be recorded and available for viewing along with the PowerPoint slides on our YouTube channel and the Great Lakes PTTC website. It will take somewhere between 2 and 3 weeks to have them formatted for that. Please use the chat box feature throughout the webinar to ask questions or to add comments. And we will have a brief Q&A session after the presentation. And I'm going to turn it over to Erin Ficker to introduce our speaker today.
Hi, everyone, and thank you so much for being here. My name is Erin Ficker, and I'm one of the 2 prevention managers at the Great Lakes PTTC. I'm just delighted that we have such a great crowd today to share this topic with us. And I'm even more excited to introduce to you today Dr. Kim Dash. Kim is a senior research scientist at the Education Development Center and has spent much of her career promoting the use of evidence-based information in public health interventions. She's a leader in the behavioral health and social health field. She's a published author. She's an expert in evaluation and fostering community resilience. She is, I could go on and on about Kim for quite a while, but she truly is an expert in evidence-based interventions in substance use and someone who I think is just absolutely perfect to bring us this topic today. So in order to just give Kim time to talk, I'm going to turn it over to her. Thank you, Kim, for joining us and sharing your wisdom with us today, and thank you all for being here. So I'm going to turn it over to you, Kim.
Great. Thanks, Erin. I see that the presentation is coming up. But before we get started, let's take a poll. Let's find out a little bit about who is who's participating in the webinar and your particular interest in substance misuse prevention among young adults. And it looks like some of you are answering. For the most part, I think we're seeing the majority of you implement prevention programs for and with young adults. The vast majority of you. Still the vast majority. Interesting. And there's a few of you who are a young adult. I think that's always great. Some of you are teaching young adults. Some funders on the line. Others who deliver direct prevention services. Great, great. So it looks like we have a good mix of people participating with us today. So I'm going to go ahead and move on into the presentation since we've got lots to talk about and about an hour to do it. So the objectives of this presentation is that we're going to talk about first, we're going to talk about recent data related to young adults and substance use. And then we're going to describe a guidebook that I developed with others at SAMHSA on substance misuse prevention among young adults. And as part of that presentation, we're going to talk a little bit about evidence-based practices that are likely to make a difference for young adults. So again, talking about the guidebook. First, I'd like to give you a little bit of context. The guide I'm going to be talking about today was a project of the National Mental Health and Substance Use Policy Lab. And as noted on this slide, the lab was created to disseminate evidence-based practices and service delivery models to prevent substance misuse, among other things. It is one of several guides in a series that focuses on preventing some of the most pressing substance misuse issues, also as defined by the lab. Each guide is meant to be a brief reference on best practices, and I'll describe later how they're organized. Today I'm going to be talking about the first guide. So when approved, the guide will be posted on SAMHSA's evidence-based resources, evidence-based practices resource center, which you can access via the URL posted here. Eleanor McCants-Katz has recently reviewed this. She had a little bit of feedback. We addressed it. So I'm hoping to see this posted soon. And each guide is meant to address the goals in SAMHSA's strategic plan. Very briefly, here's the team that developed the guide. Drs. Clark and McHale and Ms. Garrison are with SAMHSA, and Dr. Ghosh oversaw the development of all of the guides, and I served as a subject matter expert on 2 of them. And as you know, I'm going to be talking about the young adults one today. For the young adult guide, we also sought the opinions of a panel of experts in substance misuse prevention practice, science, and young adult development. This panel provided feedback at several junctures in the development process in terms of the types of programs we should feature, as well as challenges and solutions to overcoming barriers to implementation. I mean, in a nutshell, the guide was developed based on their recommendations, which I'll discuss in the latter part of this presentation. So very quickly, any questions so far? I don't think so. I'm kind of looking at the chat, but I want to make sure to check in at several moments because I'm presenting a lot of information quickly. So it looks, seeing none, I'm going to move on. There will be, I'll pause at several junctures to ask for questions. So as mentioned previously, the Policy Lab chose to focus on young adult substance misuse because data indicate that it is a pressing public health problem. As many of you know, young people transitioning into adulthood have some of the highest rates of alcohol and substance misuse in the country. So to give you some idea of the problem, I'm going to share recent data from the National Survey on Drug Use and Health, or NSDUH for short. But first, let's do a quiz. Which one of the following drugs do you think young adults are most likely to misuse? So just pick one answer. And I'll wait a minute. I think the poll has to pop up for us so we can take it. It looks like marijuana is in the lead, prescription stimulants and prescription pain relievers coming in second. Still marijuana is in the lead. Prescription pain relievers are a solid second. Okay, I'm going to move on since we, again, as I said, we have a lot of material to cover. I'm not going to answer this question right away. Instead, I'm going to go ahead and present, I'm going to present the data, and then we can come back and revisit what you all said. So briefly, some background on NSDUH. I'm not going to read through all of these points. I just want to highlight a few. NSDUH draws, as you can see here, NSDUH draws a community sample of individuals age 12 or older. So this is not a clinical or institutional sample. It's also interesting to note that NSDA excludes active duty military, which includes many young adults. And this is important to point out because we know from other data sources that deployment is associated with unhealthy drinking, drug use, and other risky behaviors. So that's an important exclusion and something to keep in mind. And then the other thing I wanted to mention is that the data I'm about to report is from the most recently completed data collection cycle. So very quickly, I'm going to go through a bunch of slides quickly, so you can bear with me. So here we can see that current alcohol use among young adults is on a downward trend, and roughly the same percentage of young adults currently drink alcohol compared to adults. You know, again, I apologize. We have grouped all adults age 26 and older together for expediency, and I imagine we'd probably see a more nuanced presentation if we broke adult groups down into smaller age ranges. But again, for the purposes of the presentation, we sort of lumped all adults together. And I think it's important to note that more than half of young adults report using alcohol in the past month. Oops. I skipped too far ahead. All right, there we go. Okay, so this data paints a different and kind of alarming picture. Over the past 4 years, a much larger percentage of young adults report having an alcohol use disorder in the past year compared to adults age 26 and older. In terms of prescription pain reliever misuse, we can see that it's on the decline in all age groups, and that young adults have the highest rates of misuse compared to their younger and older counterparts. Of note, 5.5% of young adults reported currently misusing prescription pain relievers. And by misuse, participants were asked if they used it in any way a doctor did not direct them to use. So I just wanted to mention that. Well, I keep clicking too fast. This graph shows that heroin use is declining among young adults. However, young adults have higher rates of use than other age groups depicted here, and you'll note that the rates of heroin use are relatively low compared to other drugs that we've covered so far. Now, in terms of recent marijuana use, young adults are more likely to report current use than other age groups. For example, 22% of young adults report recent use, while only 8.6% of adults age 26 and older report using in the past month. Also, we see an upward trend in marijuana use among young adults. With regard to marijuana use disorder, we see that young adults are more likely than other age groups to report a marijuana use disorder. Interestingly, as you can see here, children aged 12 to 17 report higher marijuana use disorder rates than adults aged 26 and older. And also among young adults, we're seeing a slight upward trend in rates of MUD. Recent cocaine use is higher among young adults than other population groups. However, the 2018 overall rate of use, 1.5% here, is lower than that of other drug use, and like marijuana and alcohol. And you'll note that there's a significant sharp drop in the rate from 2017 to 2018. And methamphetamine use actually mirrors, the rates of methamphetamine use actually mirror the rates of current cocaine use. And again, we see that rates of use are higher among young adults. And misuse of prescription stimulants is higher among young adults than other age groups. And again, this graph shows a significant drop in use from 2017 to 2018. And so let's go back to the poll. We don't necessarily, well, we can pull it up, but we asked which one of the following drugs are young adults most likely to misuse. And so the highest rates of recent use among young adults are for marijuana compared to the other drugs listed here. So given the fact that marijuana is still considered illegal at the federal level, then I think we can say that marijuana is the drug that most young adults are likely to misuse. However, if you disaggregate the data to look at rates by states where marijuana is legal for recreational use, for those who are age 21 and over, then you might come to a different conclusion. Abuse of prescription stimulants comes in at a distant second. So most of you, well, yeah, most of you were right. It is marijuana. And for those of you who want to play around with the NISTA data yourself, and maybe even disaggregate some of that data, you can access it here. All right, I'm going to pause again and see if there are any questions before I get into more of the meat of the presentation where I talk about the guide and the resource guide that features evidence-based practices. So are there any questions so far? Okay, I see some people are typing, but I'll catch up with you later because I'm going to pause again. All right, so let's talk a little bit about the resource guide on evidence-based prevention practices for young adults. So this guide is organized into 5 sections, and so are all the other evidence-based resource guides. The first chapter presents an overview of the magnitude of substance misuse during young adulthood, factors that contribute to increased risk generally and for specific population groups, as well as applications for prevention. The second chapter describes current evidence of effectiveness of programs and practices to prevent substance misuse by young adults. Chapter 3 provides examples of programs that use evidence-based practices for preventing substance misuse by young adults. And Chapter 4 includes practical information to consider when selecting and implementing programs and practices to prevent substance misuse, again, by young adults. And the final chapter includes guidance and resources for implementing evidence-based programs and practices, monitoring outcomes, and improving program quality. The audience for the guide is primarily providers, healthcare systems, and other stakeholders. What we discussed was that the research shows that implementing evidence-based practice requires a multi-pronged approach. Many of you know this, and so the guides would be one piece to be used to help that process occur. We focus on emerging adults. We use the term young adults. You wouldn't believe the amount of debate that we had around the term we should use when describing the population of 18 to 25-year-olds. We considered transition age youth, emerging adults, and young adults, and eventually settled on young adults. And we also wanted to make a point of describing what it is about being a young adult that places this population at increased risk. The fact that it's a time of exploration, setting out on one's own, the formation of identity and relationships. So we did do that. So for the remainder of the presentation, I'm going to describe our development process and the content included within the guide by featuring specific recommendations made by the expert panel. And so the first recommendation was that we have a guiding theory to frame the evidence on substance misuse prevention. As you can see here, our perspective on prevention practices and programs is guided by the social ecological model of development, which states that individuals are influenced not only by their biology and innate traits or characteristics, but also by the context in which they are raised. And these contexts include relationships with others, communities in which young people grow up and develop, and societal influences such as culture, historical trauma, laws and policies that affect child, adolescent, and young adult well-being. And these contexts influence each other such that policies at the societal level influence community development, which may impact families raising children. And, you know, in the same way, young people, as they develop, can exert agency and work to change these contexts. It's not really, or not necessarily, a one-way street. And with regard to prevention, we think of risk and protective factors associated with these different contexts as influencing behavior, including substance use. And these contexts are also units of practice or where we choose to intervene to influence behavior. And you know, I will point out that while we mention the social ecological model, we also reference other common theories, one of which is the cascading influences. So the effects of excessive drinking and or drug use during college can be understood as a cascade of interrelated problems that accumulate over time. And so, it looks like we have a question. Well, I'll answer that when we get to the next pause period. It's a great question. So another recommendation was that we talk about or highlight risk factors for substance misuse. And this slide and the next one demonstrate what we know about risk factors for substance misuse during young adulthood and draw heavily on a review of the literature conducted by Stone and colleagues and published in 2012. As you can see, risk factors are organized by the different socioecological levels, and there is some indication as to when these risk factors appear and exert influence. So you can see the C here is for childhood, the A for adolescence, and the YA for young adulthood. So some of these risk factors appear pretty early, and some appear later and exert influence. It's important to note that some of the risk factors at the individual level, and I'm thinking specifically of early and persistent antisocial behavior, may be markers for other sort of underlying conditions such as neurobehavioral disorders or conduct disorders. So again, it's important to not necessarily feel confined by these specific risk factors, but also consider what they may be markers for. And again, here are risk factors at the community and societal levels. You'll see that college and fraternity membership stand out as risk factors and are listed here primarily because of the influence they exert on alcohol use. Other kinds of substance use is more common among non-college attending youth. Also consider academic failure. It's possible that academic failure may be related to other issues at the individual and family level, as well as school level factors that we have not yet parsed out. And again, I think there is still some debate as to whether or not academic failure precedes or follows substance misuse during adolescence and young adulthood. So although research on protective factors is limited, there are some studies that have found that strong bonds to and support from family of origin, as well as healthy beliefs, can protect young adults from substance misuse. Other factors include social, emotional, behavioral, and moral competence, self-efficacy, spirituality, resiliency, opportunities for positive social involvement, recognition for positive behavior, and being in a committed relationship with a partner who doesn't misuse alcohol or other substances. It's also important to note that for young adults, an adaptive and protective coping strategy is help-seeking. or knowing when to seek help, feeling confident in one's abilities and comfortable enough to seek care for distress or suspected mental health disorders. This is an especially important issue for young adults who may feel like they can and should weather mental health issues alone and are accustomed to parents arranging their care or do not readily recognize that they may have a problem. And so you'll see here that this slide lays out barriers and facilitators to help to help seeking in young adults. And these are things that are important to consider when providing services, whether they be prevention or treatment. So the expert panel also wanted to acknowledge that some young adults are at increased risk of substance misuse because of the kind of adversities they face. So because they are more likely than heterosexual youth to experience certain stressors such as stigma, discrimination, harassment, and violence, LGBTQ youth are at increased risk for various behavioral health issues, including substance misuse. Young adults who are homeless, we know that social networks, economic factors, and more negative expectations about the future are associated with relatively high levels of substance use. Polysubstance use is also common among homeless young adults, and those who use substances are more likely to have co-occurring mental health disorders. Youth in foster care are thought to be at greater risk of substance misuse because of their documented experiences with trauma and maltreatment and exposure to parental alcohol and substance use. Young offenders are also more likely to experience traumatic, adverse childhood experiences, which may contribute to substance misuse in adolescence. Young adults in the military face stresses associated with deployment, combat exposure, and the unique culture of the military. Military personnel also can experience combat-related injuries that are associated with their deployment in the field, working with equipment, heavy equipment, and these injuries produce pain, and that this pain is often treated with addictive pain reliever prescriptions that can become difficult to stop taking. Those who use substances before college, especially those who engage in heavy drinking, may be more likely to join groups that support their drinking norms. And once enrolled, the social subculture of fraternities and sororities serves to reinforce and contribute to an increase in their heavy drinking. And here's an alarming stat. Compared to other college students, young men who belong to fraternities are at greater risk of heavy drinking well into adulthood, with one study finding that by the age of 35, almost half of residential fraternity members reported alcohol use disorder symptoms. Explanations for increased risk among those with ADHD include self-medication to temper moods or cope with stress, demoralization, and feelings of failure often associated with this chronic condition. Another thing that's important to point out is that compared to other developmental periods, co-occurrence of serious mental health conditions and substance use disorders is concentrated in young adulthood. We also thought it was important to point out the consequences of substance misuse. So you'll see here that there are specific effects on the brain. Up until the age of 25, the human brain is still developing, and so it's vulnerable to substances like alcohol and other drugs. And this kind of substance misuse can permanently change brain areas, resulting in a lower IQ, reduced motivation, and increased impulsivity and reduced attention span. Substance misuse is also associated with health issues including cardiovascular diseases, respiratory diseases, cancers, liver damage, kidney damage, mental disorders, prenatal defects, and others. And again, impaired driving is especially prevalent among young adults. Self-reports of driving under the influence peak for those ages 20 to 25, with 21.2% reporting a DUI. Oh, excuse me. The expert panel, so when it comes to the evidence-based criteria that we use, the expert panel recommended that we use the same criteria that the Surgeon General report used. And this is the Surgeon General report that's referenced here, Facing Addiction in America. And so here are the specific evaluation criteria that we applied to selecting programs that we featured in the evidence-based resource guide. So specifically, I want to point out that all, to be included, all programs had to be evaluated using a randomized trial or quasi-experimental design. The behavioral and social characteristics of the samples for which outcomes were measured had to be specified. The outcome assessments must have included a pre-test, a post-test, and follow-up findings. And follow-up data had to be reported more than 6 months beyond the time point at which the primary components of the intervention were delivered, so that we could examine the duration and stability of intervention effects. I want to also point out that evaluation studies of institution and community-based programs or policies were actually exempt from this rule regarding follow-up data, mostly so that we could feature more of those programs, especially since they have been applied to reducing substance misuse among young adult populations. Again, programs were included only if they produced outcomes showing a measurable difference in substance use or substance use-related outcomes between intervention and comparison groups based on statistical significance testing. And we also applied additional quality of evidence criteria such that the program had to provide, the program had to meet 7 criteria, such as reliability of outcome measures, validity of outcome measures, pre-test equivalence, intervention fidelity, analysis of missing data, degree and evaluation of sample attrition, and appropriate statistical analyses. So, because of that, another recommendation was that we just simply feature and or reference the same programs and policies that were included in the Surgeon General's report. And these were featured in Chapter 3, Appendix B, because these programs demonstrate effects on substance use or substance use-related outcomes in adolescence and young adulthood. We didn't stop there, though. There was lots of debate about whether or not we should just strictly focus on those programs. We also identified other programs and practices that we had identified through comprehensive reviews of the evaluation literature. So we included more programs than those featured in the Surgeon General's report. Oh, this slide looks a little funky here, but I think you can still read it. The expert panel also said that we should organize the programs by populations targeted. And so using the criteria that I just talked about, we identified 73 programs as evidence-based. We're preventing substance misuse among young adults. The programs fall into 3 categories: universal, selective, and indicated. I think most of you are familiar with these different types of prevention programs, but for those who are not, I'm going to define quickly. Universal prevention programs target populations at all risk levels, or typically referred to as the general population. Selective prevention programs target populations with known risk factors, such as family history of substance use disorder, and indicated prevention programs are designed for populations who are already exhibiting substance misuse behaviors, such as underage or binge drinking, but they don't have a substance use disorder diagnosis. So in this chart, I'm going to point out that one program was counted in 2 categories, since the approach is different depending on the age group targeted. And next, one of the recommendations was that we distill prevention practices from programs. So here, and for prevention, our process is really different than that employed in some of the other guidance documents, because we started with the programs, and then from there we distilled practices commonly implemented by programs with evidence of effectiveness. And these practices are listed here. I'm going to highlight a few. So for example, full-service schools provide comprehensive academic, social, and health services for students and students' family members and community members. And I'll stop here, and I want to point out that you'll notice that we're focusing on both children and adolescents and young adults. And when we started out, we thought we might focus only on young adults, but it was felt that it was really important to focus both on adolescents and young adults, because adolescent initiation of substance misuse during adolescence is a major predictor of substance misuse in young adulthood. And so for that reason, we wanted to highlight programs targeting both adolescents and young adults. And so you'll see that there are programs featured here that are implemented very early in the developmental trajectory, such as home visiting, which is actually provided to expectant parents or families with young children to teach positive parenting skills and parent-child interaction. They promote strong parent-child communication to stimulate language development, provide information and guidance on a range of health and health-related topics. I mean, essentially, these kinds of strategies are implemented to prevent adverse childhood experiences. Another strategy worth highlighting is social and emotional skills education, which helps children and adults learn to understand and manage emotions, set goals, show empathy for others, establish positive relationships, and make responsible decisions. And this can help youth develop social competencies with communication, self-efficacy, assertiveness, and substance resistance. And for a focus on young adults, I think one particular prevention program worth highlighting is screening and brief intervention, most likely because it is implemented a lot. It includes a validated screening tool sensitive to a given substance use problem, followed by a brief intervention based on the results of that screening, and then includes tailored feedback about screening results, concrete advice based on medical concerns, and support for individual goals. Again, each of these practices is described in detail in the guide, but I just wanted to pull out a few. And I think it may also be worth talking about what we mean by environmental changes here. And what we mean is that these are changes that alter the social, legal, or physical context in such a way as to help individuals make healthy choices. And they often combine multiple practices like communication campaigns, screening and brief intervention, policy and enforcement. So essentially, that's kind of our catch-all for multi-component interventions that include some strategies that address context. So the expert panel recommended that we feature 7 evidence-based programs. And again, as I mentioned, we had aimed to include programs that were implemented with young adults only, but after a lot of discussion, we determined that it made better sense to focus on programs implemented during young adulthood childhood and late adolescence. Again, related to the factors around initiation. And so we focused on identifying programs that targeted universal, selected, and indicated populations and different levels of influence. And the programs are listed here. We feature Adults in the Making, which is a social emotional education program for older adults and their parents. Alcohol taxes target societal level factors that affect availability of alcohol. Basics, or brief alcohol screening and intervention for college students, targets individual level factors to reduce high-risk drinking behaviors. CMCA, or Communities Mobilizing for Change on Alcohol, addresses environmental change, including community norms, laws, and enforcement. Family Checkup seeks to improve parenting skills and relationships between parents and children. Safer California Universities addresses policy enforcement to reduce access to and availability of alcohol. And Team Awareness is a social norms education program that's designed to bring about individual and workplace changes. So again, we feature 7 programs, but I will point out that all the 73 programs I referenced earlier are included in an appendix and featured there with some essential information. And so for each of the 6 programs we feature, we provide a short description of the program. Again, these 7 programs are only meant to be exemplary or illustrative, not necessarily even exemplary, but illustrative of what a prevention program looks like. So again, we provide a short description of the program. We explain the mechanisms of change, why the program is thought to work. We include implementation requirements such as training or staff credentialing. We mention outcomes based on program evaluation. We also include information on the substance targeted. Is it alcohol, marijuana, or opioids? We indicate whether it's a universal, selected, or indicated prevention program. We highlight the risk and protective factors addressed, and these are the risk and protective factors that are defined by the program developers. We highlight the settings where it's implemented, where they're in a college setting, workplace, clinic, community. We indicate how long it takes to deliver the program to a single group of participants. And we also include links to any resources that might help with implementation. Okay, I'm going to pause. And I do see there are questions here. I'm scrolling up. And so the first question is, how did we define misuse? So we defined misuse to include, and hopefully I won't butcher the definition, but so misuse includes essentially problematic use and also illegal use. And so for example, underage drinking would be considered misuse. Heavy drinking would be considered misuse. Any use of an illegal substance would be considered misuse. So again, I hope that's helpful. And then the next question is, will you be presenting information on what caused the downward trend in some of the drugs? Oh, actually, I will not, but I think we can all, I think it's worth, perhaps that's worth another presentation at some point. We can certainly talk about why we think there's a downward trend. As much as I could tell, these downward trends were not statistically significant, except in a few cases. I think the drop in cocaine use and I think it was methamphetamine use. Those were statistically significant drops from one year to the next. So I would sort of caution, you know, we talk about it as being a downward trend or an upward trend, which may not be significant. And then, oh, lots of data questions. Is opioid use rising faster than other substances? Also, how does molestation play into substance misuse? And then we have a response from another participant. Equal molestation equals trauma. Any type of trauma, yes. I definitely think there is a connection between trauma and substance misuse. There's also a strong connection between trauma, early trauma, and violence and aggression. And it says here, can you please share again when these guides will be available? So as I mentioned previously, the guides are being rolled out as soon as Dr. McCants-Katz is able to review them. And ours was recently reviewed, and as I said, she had minimal feedback on it. We've addressed her comments, and you know, I'm happy to follow up with Shadia Garrison at SAMHSA and get back to you with a specific date as to when this might be released, and I can certainly pass that along to the folks at the PTTC. Oh, there's lots of questions coming up. I see, is NREP ever going to come back? To be honest, I'm not in a position to answer that question. I think that's a question for SAMHSA, and I can't really speak for SAMHSA. Oh, this is a good question. When was the last time that CMCA was evaluated? Were there any reviews that determined that CMCA was not effective in some communities? So it has been a while since CMCA was last evaluated, and I will say I think there are some mixed results on CMCA. I was actually asked to re-review a lot of the evaluations of programs that were included in NREP, and we did turn up some mixed results with regard to CMCA. However, because it was featured in the Surgeon General's report, we did include it, but the program description does include the warts. Like, it's there, warts and all, in terms of some not so promising findings. Okay, so in terms of marijuana, if it's not legal in a state, does that mean that use was defined as misuse? Yes. And we are looking for an alcohol prevention curriculum. That might be something I would do offline. I feel I would probably recommend, I could include many recommendations rather than just one. So I see that we have like 10 minutes, so I want to make sure that we're able to get to some of the last bit of content. So I'm going to move on, and I'll pause. All right, so moving along, the expert panel, when it comes to implementation, the expert panel recommended that we use the SPIF, which I think you're probably all familiar with the SPIF, and they recommended that we use this to guide implementation of evidence-based programs. So as you may recall, when I went through the outline, we have a chapter dedicated to implementing evidence-based programs and practices. And so essentially we frame that chapter according to the steps of the SPIF. And for each step, we ask the expert panel to name specific challenges to implementing prevention programs targeting young adults and some solutions to these challenges. And so I'm going to walk us through some of these pretty quickly. I'm not going to read off all of these. I'm just going to highlight a few, but these slides will be available to you after this presentation. And so when you look at this slide, you can see. Let's take a look at the first one here. So we can see that organizations may not be ready or may be resistant to innovation, and so you might assess staff knowledge, attitudes, and efficacy related to implementing a best practice to prevent substance misuse and provide feedback to motivate staff. This is a common practice. We've done it before here at EDC. We do institutional assessments. We build them into programming to help motivate staff to implement innovation as well as highlight any gaps that might need to be addressed as part of the implementation process. And then in terms of capacity challenges, one of the things that I think stands out here is staff not having the appropriate skills or credentials to implement a program. And so in some cases, this might rule out the implementation of a specific program or practice. If you don't have the staff with the right stuff, then it may not be a good idea to implement it. But, you know, it may be possible with support from organizational leadership to provide or fund professional development for staff so that they're able to obtain the required credentials to implement the program that you select. In terms of planning, we sometimes can't find programs that address the populations we serve or that were not developed for the settings where we work. And so in these cases, we can create new programs based on formative research with the populations we serve. But this takes time and it takes a lot of resources. So instead, we might want to adapt an existing evidence-based program. But, you know, even with adaptation, we need to involve populations served and, you know, as well as those who are implementing the program to determine whether or not it's going to be feasible and whether or not our adaptations are likely to be productive. And here, notable among the implementation challenges is that staff sometimes, you know, sometimes they you know, lose their enthusiasm for a program because they're not getting immediate visible results. And, you know, this may be especially true if the program takes a long time to implement. So in these cases, it helps to provide ongoing feedback to staff on implementation successes, or you can offer rewards or recognition or other kinds of incentives. And then when it comes to evaluation, I wanted to highlight one of these challenges, and that is, why should we assess outcomes when we're implementing an evidence-based program, right? That seems like an appropriate question to ask. And this comes up all the time. And it, you know, it simply may make more sense to focus on implementation evaluation and continuous quality improvement rather than outcome evaluation, especially if you have limited resources. But if you adapt the program, you'll want to see if it produces the outcomes you expect. And also funders or administrators may want to see those behavioral outcomes. It really depends on you know, where you're working and who is funding your program and the program you're implementing. And then lastly, before I reopen for questions, I want to mention a few caveats about the guide and the development process. I feel like here's where we talk a little bit about the limitations. So, you know, as you can see, based on the examples featured, most of the programs targeting adolescents and young adults are implemented in the school setting. So that's kind of limiting. And we were not able to find many programs for young adults in the workplace. Most programs target alcohol use, which, you know, it's understandable given the rates of use and misuse and alcohol use disorder among young adults. But, you know, it would be interesting to know whether or not some of these evidence-based programs have been evaluated for their effectiveness in reducing other substances. And so a lot of that work is yet to be done. More innovative programs employing mobile health technology are not featured in the guide because they have not been adequately evaluated. However, I want to point out that there is a researcher, Michael Mason, and his team. They've been developing a mobile phone-based platform that uses text messaging. This is referred to as a peer network counseling text. and they adapted the basics model, which we mentioned earlier, and they adapted it for students who are heavy cannabis users. He's conducting a 4-week pilot, and he found promising results. Students were highly receptive to the text messaging format, and students completing the program reported fewer heavy cannabis use days and relationship problems due to cannabis use after 3 months post-intervention. And he has a large multi-site study underway that's being conducted at Colorado State University and the University of Tennessee, Knoxville. So there are some innovative things on the horizon, and I would encourage you all to not necessarily feel restricted by the kinds of, by the specific programs that are included here. We should always be looking for, those kinds of innovative approaches, especially ones that use mobile technology, which young people are likely to, which young people use a lot. And finally, it's not clear what effect many of the evidence-based programs have on populations at increased risk. For example, LGBTQ youth, homeless youth, and whether more tailored programs or practices are needed. And so I would say, there is still some work to be done in terms of innovation for populations at increased risk given some of the adverse experiences they face. So, excuse me, I'm talking fast. All right, so I see that there are more questions, and we have about 3 minutes, so I'm going to try to hustle through some of these. I see a couple of new ones. I just see one new one. How would you approach schools with prevention where there is not significant data to support opioid use, but this is the target topic? That's a great question. So I think one of the ways I would approach this is by talking about risk and protective factors for opioid misuse, and starting there and pointing out that there are many kinds of programs or strategies or practices that can be implemented to address those risk factors, which are often common to or shared across other kinds of substance misuse. I know, for example, one of my colleagues who's also with the Great Lakes PTTC, Chuck Klevgard, is working with schools in Indiana who initially started with this particular focus, and after taking a hard look at the kinds of evidence-based programs out there, decided that they wanted to focus mostly on social and emotional competencies, and decided to implement curricula that focused on those particular protective factors. Okay, so we have 2 minutes. I'm answering quickly. It looks like there are other questions in the chat about getting the presentation materials, and those are being answered. Again, if there are no other questions. Oh, yes, the colleague in Indiana, it's Chuck Klevgard. Let me type it here, or maybe Aaron can type it into the chat. Yeah, he's working with several school districts in Indiana. So if no other questions, I thank you so much for your time, and have really enjoyed talking with you today about substance misuse prevention among young adults, and you all are doing such great work. And if you have any questions for me, please feel free to email me. Thanks so much.
Thank you so much, Kim. That was a great presentation. We will include information, emails, contact information in an email that we send you with an evaluation. So if you have any other questions, you'll have some contact information. Again, I appreciate everyone's time, and have a great day. Thanks. you.